Okay, it's a Netflix series.
Okay.
I was seeing that and I said, okay, this suits our symposium title, How to Get Away with Aphakia.
Yeah, the same problem for me. That's why I worn my red shirt actually to match the background. Now I'll show it better. Yeah. Now the screen is filled with red.
It's a Netflix series.
Good evening, sir.
Good evening. So what I see, there are a lot of Venkatesh now.
No, this is they're just putting live on YouTube. Okay, so mama, there are a lot of Venkatesh. இதெல்லாம் ஏன் பேர்லயே வருது? எல்லாம் இண்டிவிஜுவல் நேம். எல்லாம் ரீநேம் பண்ணுங்க. எல்லா பேனலிஸ்ட்லயும் என் பேர்லயே போடு. இல்ல சார் தனித்தனியா பேர் கொடுத்து போடு. அனுப்பிடுங்க சார் அவங்க போடு. எல்லாரையும் ரீநேம் பண்ணுங்க. You have a minute to go.
What's the time now in Bondi?
It's 6 now.
6. So it's dark, huh? Outside.
Yeah, we are getting it's the start of kind of winter now.
Not exactly winter. We have got only 3 seasons: hot, hotter, and hottest. Now from hottest to hotter. Next we'll go to hot.
அது என்ன ஸ்ப்ரிங்னு சொல்வீங்களா? நரேஷ், நம்ம ஊர்ல ஸ்ப்ரிங்னா என்னன்னு தெரியாது நமக்கு.
We don't know. We don't have 4 seasons. So we
but the hot starts in December or so, no? There is a little rain or whatever, and then the horrible season starts from April, May, right?
Yeah, hottest will be April, May. Now it is hotter.
Yeah. When you start பண்ணியாச்சா?
So when we listen to Vivaldi, we are confused. What is that 4 seasons he is talking about in his music?
Okay.
Oh,
Naresh,
thank you.
We'll start. Yeah. It's a pleasure having you all for this symposium. It's a time where we are going to celebrate my good friend Gabbar, who came up with this brilliant idea. He was telling me even way back in 2002 and 3 about how to fix a haptic into the sclera, and I was thinking, what is he talking about? I was taking him lightly, but I know he's a great innovator. But over the years, the last at least 15 years, this has come a long way. So this symposium I'd like to dedicate, in fact, to celebrate the Chariot tunnel. That's what I'm calling it. And we have 4 great innovators with us in this symposium. In addition to Dr. Chariot Gabbar, who doesn't need any introduction, I always remember how Kelman was rejected to begin with. So even Gabbar was rejected in 2015 and 16. 2005 and 6 for his technique. And then he had to literally pursue over his idea and then make it a technique and people to believe it that it's a great technique. And then there are so many incremental changes. And we have another great innovator who will be joining with us a little bit later because he's in theater now, Dr. Sergio Canabrava from Brazil. Again, all these people were motivated by the Chariot technique. And I have my colleague and good friend, Dr. Prabhu from Chennai, Aravind, who innovated a great idea of doing a little bit easier for people who do small incision and the scleral fixation by kind of extraocularly threading the haptic. So there was another incremental change to Yamane's technique and Gabbar's technique. And we also have one of our great alumni, Dr. Nivian, with us. Again, all these people, I don't want to waste time in introducing. They're all very popular now for their innovations. So Nivian has come up with an excellent lens model. He thought even out of the box. He said, I have to design a new lens for Aphakia. And then he has designed it. And then he has worked closely with the company locally. And now it's a product. So he has not only stopped from innovation, he has also made it into a product. Same way, Prabhu also has made a product for XNIT to do comfortably. So we have some 4 excellent speakers who are going to share their innovations. And this will be followed by our eminent panel, all from Aravind. We have Dr. Haripriya from Chennai. Again, she needs no introduction. And we have Dr. Shivakumar from our hospital in Tirunelveli. And my good friend, Dr. Naresh with the red shirt. Oh, Haripriya is also on a red saree. So I was telling why this background, no, to Gabbar, how to get away with murder. It's a series in Netflix. I've been watching this series in the recent past, and I said it really suits this topic, how to get away with aphakia. So we have again an vitreoretinal expert, Naresh, with his thoughts about how he's been doing this for several years. So we'll have a discussion with few cases after the 4 talks. And then finally, I think Sergio has also promised to join a little bit later. We can have some question answer sessions once we have the question answer coming up in the chat. So we have very good attendance. In fact, we have 200 plus registrations. A lot of attendees are joining, and I don't want to take much time. It's 6:05 now. So we're going to start with the recorded talks. We're going to play first Dr. Gabbar's talk. Optimize பண்ணிக்கோ.
I'm Gabor Schariot from Aurelius Augenzentrum in Recklinghausen, Germany. First of all, I would like to thank Dr. Venkatesh and the Aravind Eye Care System team for the invitation to this important meeting about how to get away from aphakia. My presentation is about my 20 years experience with implantation of IOLs in eyes with insufficient or no capsular support. You see all the places throughout Europe where I'm working and my financial disclosure. Exactly 20 years ago, I gave my first lecture about how to deal with subluxated lenses. And at that time, we had quite a lot of solutions how to fix an IOL in these eyes with insufficient capsular support. And there was, of course, the anterior chamber IOL, which I'm not using for more than 20 years. And I used to say in this millennium, I'm not using anymore the anterior chamber IOL because of the known problems like endothelial cell loss, dislocations, iris capturing, secondary glaucoma, etc. And we had iris fixated IOLs like the artisan lens, anterior chamber fixated or retropupillary fixated, the binder lens, suture fixations to the iris. We had sulcus fixated IOLs with or without sutures, with different kind of sutures. Then we had the in the bag fixation with capsular tension ring, which most of the time was not sufficient, then with modified capsular tension rings, suturing to the wall, etc. I would illustrate you why I was not satisfied with suturing, which I did some years, and actually which turned out later that instead of many techniques and variations, there were the problems with all of these, the knot erosion, IOL tilt, and suture breaks. And with the courtesy of Boris Mayugin, you see these photos of electron microscopy images of sutures with very early degradation of the material. And it explains why we have these late dislocations of the IOLs with suture fixation about 8 to 12 years post-op. And of course, this is more stable with different kinds of suture materials like you see on the right bottom. But then you have more frequent knot erosions, etc. And do not forget that you fixate the IOL quite near the ciliary body, and the large area of the haptic is actually touching the ciliary body or the iris back face. This is the problem I would like to illustrate with this video with the artisan IOL. In some eyes, especially in younger patients and myope patients, etc., you see quite intense IOL wobbling. And we had patients, they had really suffering from this problem, so we exchanged the IOL. Then if you fixated anterior to the iris, endothelial cell loss with late corneal decompensation is of course another problem. And late dislocations due to iris atrophy is also well known in these cases. Cystoid macular edema might be also occurring in these eyes. In 2006, so 15 years ago, we developed a technique in Recklinghausen, which we called intrascleral haptic fixation. And this technique is completely sutureless. And once we submitted after initial experience, good experience with this technique to the JCRS, it was immediately rejected as dangerous and unnecessary technique. Fortunately, after resubmitting this paper, it was accepted and published in 2007. And here's the technique I would like to illustrate you with this video. After opening the conjunctiva, I'm using a 23 gauge cannula, and on the sclerotomy is made 1.5 to 2 millimeters posterior to the limbus, which should be the area of the ciliary sulcus. If I am too anterior, the iris would move, and then I go 0.5 millimeter posterior. The second sclerotomy is made exactly 180 degrees on the opposite side, and then with a fresh needle starting from inside the sclerotomy, I prepare the limbus parallel intrascleral tunnel, which I used to prepare in the beginning 2 to 3 millimeters. Now I find it at 1.5 to 2 millimeters is long enough. Then a foldable 3-piece IOL suitable for sulcus implantation is implanted through a corneal incision. And then with the help with 2 special 25 gauge forcepses and the so-called handshake technique, I'm presenting the haptic, grasping near the end of the haptic, and then going with the straight forceps through the sclerotomy, grasping the very tip of the haptic and temporarily externalize it. Do the same on the opposite side. You are now in an absolute safe position. You cannot lose the IOL in this moment. And it's very important that you have a continuous intraocular infusion that can be either, as here shown, an anterior chamber maintainer or a Pastana infusion, because that stabilizes the globe, and you don't have to put viscoelastic, which you cannot remove afterwards from the posterior part of the eye. Again, here grasping the very tip, externalizing it. And now comes the intrascleral implantation. I use now my curved forceps, introduce it into the intrascleral tunnel, push it through, then open the jaws of the forceps, close them, and turn a bit the forceps that prevents the withdrawal of the haptic. Do the same on the opposite side. And this is what I call pushing technique. You can come also from the distal side of the tunnel and then grasp the haptic in the sclerotomy part and pull it into the scleral tunnel. And this is a very nice thing with this technique. You can even do a fine tuning at the end. So it's not like with suturing where you have fixed everything. So if you are not completely satisfied with the position of the IOL, you can reposition it a little bit with the Sinskey hook, for example. Another beauty of this technique is that you can use it also in eyes with no iris support at all. So in aniridic eyes, this is in one example, 30 years after severe trauma with aniridia and aphakia. And you see how I'm implanting the IOL, the same technique as shown in the previous video with an excellent centration. And finally, I add a suture fixated artificial iris. The patient had finally an 60% uncorrected visual acuity, and with correction, they had 80% visual acuity everything went well. Even more than 10 years now post-operative, he's fine. He suffers a bit from a secondary glaucoma, which was also there prior to this secondary implantation. In the recent decade, I would say, so 10, 15 years, I have to deal with more and more late dislocations of the entire capsular bag IOL complex, even with CTRs in place. Of course, there is an increasing risk in eyes with pseudoexfoliation after postplanar vitrectomy, high myopia, post-uveitis, etc. And we have to deal with these eyes. And one option is, of course, to explant the IOL. Another option is to free the IOL from the capsular bag, explant the capsular tension ring, and then, if the IOL is suitable for intraocular fixation in the ciliary sulcus, so a 3-piece IOL usually, you can try to re-implant these haptics. Obviously, this would be a much smaller surgery, as you don't need a large corneal incision, or you do not have to cut the IOL intraocular, etc. And in some cases, this was really successful. But what we saw in some cases, especially after reimplantation of sensor AR40, was a twisted optic syndrome. That means that the haptic were perfectly positioned, but the IOL optic was twisted around the haptics. And this is, I believe, due to weakening in the optic haptic junction. We haven't seen that in all IOL types, but it was more common with sensor AR40. And this is the reason why I stopped actually reimplantation. And what I do now for a couple of years is that I explant these dislocated capsular bag IOL or even IOL CTR complex, and then reimplant a new fresh IOL. One other reason is that a lot of these IOLs I found actually damaged not just the haptic, losing the memory of the haptic, not just damaged optic haptic junctions. Also, in a lot of eyes, there were smaller or larger damages after YAG capsulotomy to the optic. And I think then it's reasonable to exchange the IOL. And as now in the last 10, 15 years, more and more we are using single piece IOLs, this problem becomes more evident, that we see dislocated complexes with one piece IOLs in place. And as the most frequent implanted IOL is the Acrisoft single piece worldwide, with millions of IOLs every year, we see more and more eyes with dislocated Acrisoft or other single piece IOLs. And here I would like to show you a case where I tried to do the reimplantation technique with an Acrisoft single piece to keep the incisions small and to keep the whole surgery less traumatic. The modification was that the limbus pearl intrascleral tunnel was performed by a 20 gauge needle. So the tunnel was much larger to allow actually the implantation of the much thicker haptic of this single piece IOL. And then lifting the IOL with the special forcepses, that was the straight one of the 25 gauge set. And then handshake technique, externalizing the knob or the end of the haptic actually, and then implanting finally this knob into the pocket. And we found actually initially quite good centration of the IOL. The eyes were quiet. There was no sign of problems in the first months post-operative. You see here again the manipulation. What we found intraoperative is more difficult to well position without twisting the haptic, because a single piece haptic is much more elastic, and then it can happen that you twist around the haptic and then it can cause an intraocular tilt of the IOL. So it's much more difficult than with a 3-piece IOL. We use that as currently there are no good 3-piece IOLs with a multifocal optic available. We used also Panoptics, for example. This is a younger patient who had a special job and could not wear glasses. And it was after trauma and several retinal surgeries, but his vision was still good. And so we used here the Panoptics with intraocular implantation. Another indication for this could be also if you require IOL diopters, more than 30 diopters, and very short eyes, because they are usually not available in 3-piece design. So there can be indication to use an AcrySof, and as you see here is a very good centration of the Panoptics. The vision was very good with this patient. And initially, it looks quite nice. On the left, you see the image of a slit lamp, quiet eye, no inflammation. Hardly you can recognize the haptic of the AcrySof. Then an OCT image showing the square edge of the haptic. But in 50% of the cases, after months, we saw an erosion through the sclera. And I believe this is due to the thicker haptic, and we trimmed then the haptic. We left the IOL in all these cases. We trimmed it, so we cut it a piece so it became thinner. Then we sutured the sclera over this eroded area and the conjunctiva, and in all these cases it went fine. So if I need a 30+ diopter IOL, I still use now the AcrySof for the implantation, but I trim immediately the haptic. We are working still on to standardize these implantation technique, and currently, or at the moment, I would not recommend it for a routine use, but in special cases, it can be used. What about complications with this technique? The most frequent complication after intrascleral haptic fixation, like after sutured IOLs, is an iris capture. This is related to IOL tilt, anterior positioning, very young patients, myopia we found in a reason, floppy irises, then also sticky iris. I will explain that in a moment. Then optic design and size, of course, as bigger the optic is, as less frequent it is. And I found it also more common in hydrophobic IOLs. Here is a video to illustrate you why I think this happens. After the IOL was perfectly positioned, and now I put an anterior chamber maintainer, and you see a reverse pupillary block, which I can release with a typical maneuver. And then I perform a peripheral iridectomy. And it does, and then the reverse pupillary block with the increased risk for iris capture does not come back. And so this is the solution in these cases. So nowadays, at the end of the surgery, I always test during the hydration of my incisions whether I have a sudden deepening, like a reverse pupillary block. Then I perform a peripheral iridectomy. If I don't see that, I usually do not perform in routine cases a peripheral iridectomy. And for the illustration of this, you see also a case with reverse pupillary block on the right side and the OCT image, and after the iridectomy and denormalization of the anterior chamber depth. Another problem, like in all cataract surgeries, secondary implantations, actually in all intraocular surgeries, is cystomacular edema post-operative. And this can happen. I would say it's less frequent in intrascleral haptic fixation due to less contact to the uvea compared to all the other techniques, but it can happen. And we made a mistake that we used also Osidex implant, and I can tell you, it comes in front in all of the cases after a while. So there is an extreme risk that the implant comes anteriorly, and then you will see an endothelial damage. You can have uveitis, glaucoma, hemorrhage syndrome, etc. So I would recommend now Nevanac eye drops, azolamide tablets, And then if this does not help, parabol or intravitreal triamcinolone injections, but please do not use Osidex implant. Then there are special cases with subluxated lenses or lens coloboma. And the question was, how can we deal with them? Most of the time, I removed the whole capsular bag and then did intrascleral haptic fixation. But we tried also this technique, which is illustrated here, with very careful lensectomy, then capsular tension ring implantation, IOL implantation. You see that the IOL is still not well centered in this case. And then we used 2-3 iris hooks with implantation into the capsular rexes and then pulling them, and intrascleral haptic fixation of these iris hooks, and very well centered IOL in this case. So once the pupil is closed, you would not recognize that there is any problem. The capsular bag very stable, but it's a very complicated surgery with higher costs. And I would recommend that really for selected cases, some of the very young patients, you can try to keep the diaphragma more stable, or better diaphragma than if you remove the entire bag and put in intrascleral haptic fixated IOL. So for selected cases, this is also an option. We will see what will the future bring. Susan Jacobs developed a special capsular tension ring, which you can fixate to the intrasclerally. It's the paper clip technique. And there's not much report currently on that, but I think this is also a very promising technique. After more than 15 years of experience now, what I would like to say is that it is a very standardized technique. And if you follow the rules, you will have very good success. You perform a symmetrical series sulcus sclerotomy, 1.5 to 2 millimeters post-limbal. They should be exactly 180 degrees from each other. Then the intrascleral tunnel should be performed with a 23 gauge cannula, sorry, or a 23 gauge MVR blade. Starting from inside the sclerotomy, please perform a vitrectomy, at least a deep anterior vitrectomy or a pars-plana vitrectomy. Then remove the capsule. The capsule makes no sense, so all the remnants should be removed because that can cause a tilt or a decentration of the IOL. Use definitely and continuous intraocular infusion, either acementina or pars-plana infusion. Fixate the haptics completely intrascleral, that prevents late erosion. Use proper instruments. For example, the Forceps I developed, or some similar 25 gauge Forceps. And in case of leakage, please suture the sclerotomies, because early leakage and hypotony is the main cause for dislocation of the haptics, because otherwise we haven't seen late dislocations. It was always in the first couple of days or weeks due to an early post-operative hypotony. After 15 years, what are the pearls? What is our experience? We had no real contraindications, I would say, except severe scleromalacia, which is very, very rare. And also in these cases, you might find the positioning of the IOL where is some remnant good sclera. It's a good standardized technique, so everyone actually could learn the technique. And you can use your standard PC IOLs. That means no extra storage, easy logistics. For the biometry, we use the SRKT formula, and we calculate for intracapsular positioning of the IOL. We found excellent centration, and look on the right upper image. This is the multifocal IOL with intrascleral haptic fixation, very well fixated, and you all know how important it is in multifocal IOLs. It's completely sutureless, and the sclera is the strongest tissue, don't forget that, and I think therefore it's the best tissue to fixate an IOL. It shows minimal uveal contact and therefore prevents uveitis glaucoma hemorrhage syndrome. And in the middle image, you see an OCT image with the haptic completely intrascleral. It is completely independent from iris changes. So once you master this technique, you can use that for traumatized eyes, aniridic eyes, etc. And also we could use special IOLs like multifocal or toric IOLs. More recent research in PubMed found that there are more than 200 publications now related to intrascleral haptic fixation. And I think this is really a revolution, a new technique that became very, very popular all over the world. If you have questions, please do not hesitate to contact me. This is my email address, and I will be happy to help you and to answer your questions. Thank you very much for your attention, and I hope you will enjoy the rest of the meeting.
Thank you, Dr. Gabor. So next we'll have Dr. Sergio's video. We'll have the discussion at the end of the 4 videos.
Hello guys, a great pleasure to be here in this How to Get Away with Aphakia. Thank you, Dr. Venkatesh, for the invitation. It's a great pleasure to be with this great team, especially Dr. Scleral, that I am a great fan of his technique. I am in vacation today. That the day that I'm recorded is my pre-day before my vacation. I will try to go online to discuss, but to the beach. Okay, let's talk about the Canberra double flange polypropylene technique, 10 surgical tips. Let's start to discuss. Here, my disclosure about the technique. When everything started, it's in 2016 when I saw the Yaman technique, and I have the idea why not to use this flange with a haptic. And so in 2017 I published it in the ASCIS Film Festival and received my first prize. So I keep research it, and I have the idea I don't need a haptic from the IOL. I can use a simple polypropylene, and I start my research again in 2017 and publish it in 2018. It was the first video that I present in the like a paper in ASCIS 2018 with a patient with Marfan syndrome in using a CTS. So between 2017 and 2019, nobody was talking about the Canberra technique, but in 2019 it's become so popular, and every day you see in surgery a lot of surgeons using the double flanged polypropylene to develop a new technique, especially Dr. Kiyosaka, 2 years fixation, Dr. Noé Rivero, Dr. Ehud Asia, Dr. Kate McCabe, Dr. Yuri McKee, and it's a great honor for me to open doors to use it. Today, my 10 tips to who start the technique with these 5 years in research, these tips to avoid complications for you. Material needed. I have researched with 5-0 and 6-0. With 5-0 polypropylene, I suggest 26 gauge needle. With 6-0 polypropylene, I suggest 29 gauge needle. My research was with CTS and no foldable IOL, and foldable IOL with 4 eyelets. With CTS and no foldable IOL with PMMA, the traditional IOL to scleral fixation, I suggest 5-0 and 26 gauge needle. With a foldable IOL like Acros, like Physiol micropore, I suggest 60 and 29 gauge needle. Let's go to tip 2. To tip 2, I suggest the polypropylene test. Observe in this video how it is important to insert the polypropylene inside the lumen of the IOL before to start the surgery, because sometimes you can't insert it because the polypropylene or the lumen of the needle is so is not don't have the good size. Okay, tip 3, mark 2 millimeters. Recently have a study that suggests to use a scleral fixation with 2.5 millimeter, but my research with 2 millimeters and it works well. Here I have a force-flanged marker to mark these 2 millimeters from the limbos, as you can see. But if you don't have a marker, I suggest you do it with in the sleep lamp, for example. Number 4, a long scleral tunnel. This is so important because if you don't do a long scleral tunnel, it's difficult to insert the flange inside the tunnel at the end. If you go straight, sometimes it's impossible to insert the flange inside the scleral tunnel. Here you can see this video. I'm using a needle, 29 gauge needle. Observe how I go in the sclera, the stroke of the sclera, and so after to produce the tunnel, I rotate it to the anterior chamber, and then I insert the polypropylene inside the lumen, and observe how I back with the needle to the same scleral tunnel, the same movement. I go, rotate, and rotate again with the same movement. Number 5, push the polypropylene into the eye. Observe, I'm inserting the polypropylene inside the needle. If you don't push with the another hand, observe now I'm pushing and remove the needle. If you don't push, sometimes the polypropylene can go out of the lumen. Then I suggest when you remove the needle, go with the 2 hands and push it out. Number 6, hold the base of the prolene with some tension. Here you have a picture that you have a head arrow that you observe. I have in the head arrow a 23 gauge micro forceps. It's important you pull the polypropylene, get some tension with the IOL or with the CTS, and so hold the base, and so you cut. If the polypropylene stay with no tension, the IOL, where you have no tension inside the eye, you can have some tilt. Okay, here the picture 2. Observe after I cut it, and the 23 gauge microforceps holding the base of the sclera. Number 7, cut about 1.5 millimeter to 1.2 to 1.5 millimeter and dry the prolene. Observe this video. I'm cutting it. Don't need a long. This is about 1.5, but if you have 1.2, it's okay. Serge, how do you know this size? Observe the distance between the limbos and the base of the prolene. You have 2 millimeters in this distance. Then you need to do less than this 2 millimeter, and so dry to have a good flange. Flange size number 8. Here, observe, you don't need a big flange. You don't need, because you have a long tunnel. Okay, if you have a big flange, you can have an inflammation in the conjunctiva, for example. Observe, then I can insert it inside the scleral tunnel, as you can see in the follow tips. Secret of the flanged side. Observe 1.2 to 1.5. If you measure between the limbos and the base, you have 2 millimeters. Then you need less than it. Okay, left size, green arrow, good size. Bad size in the right side of the screen. You can see look, the size of the flange. It's impossible to insert it inside the scleral tunnel. You can produce, like you can see, it's my patient, one of my first patients, big flange, and I had conjunctival erosion and inflammation in the conjunctiva. Then I treated it with moxifloxacin and corticoid for 7 days. So I back to the operation room and reduce this flange and insert again inside the scleral tunnel. And number 9, bury the flange inside the scleral tunnel to avoid what you saw in the last slide. Observe, here I have cut so small, don't need to cut so big, and then observe, and then I will insert it inside the scleral tunnel, but you need to do a long tunnel. Okay. Here, number 10, be careful when piecing IOL. I know I was I think I was the first surgeon to discuss it when I was discussing about foldable IOL for the false flange technique, but in my research, I have some problems. Sorry for to go to this slide, but I have some problems with tilt when I do a piece in the IOL. Then be careful. I prefer to use to fold the IOL, the acrylic IOL, or to use the micropropyl. Guys, thank you. Dr. Venkatesh, thank you. It's a great pleasure to be here. I will try to connect. When you invite me, I told you Friday is my operating room day, but I didn't realize that I will be in vacation, the holiday here in Brazil. Thanks for the invitation.
Good evening, all of you. Let me just take you through some of the works that we have done at Aravind in the past 5 to 6 years in the field of esophageal surgeries. Yeah. So this is one of the most crucial steps in esophageal surgeries. Exchanging the tip of the haptic from one instrument to another at the anterior vitreous face to externalize the trailing haptic. So this challenging intraocular maneuver, maybe it's quite Gabor does it quite elegantly, but for most of us, it's quite challenging, I would say. So check this video. So I'm trying to exteriorize the trailing haptic. The globe is soft, probably post-trauma and post-vitrectomy as well. So lost. I'm trying to catch it, but lost it. So at another situation, this is quite challenging because there's a dense corneal scar. I will not be able to see the tip of the haptic. I'm trying to visualize it. It's quite difficult. I need to maneuver under the scar, but it's very difficult for me to catch the exact tip. Unless you catch the tip, it's very difficult to exteriorize the trailing haptic. I think I've already lost it. So this challenging intraocular maneuver is what forced us to think little differently, and hence we decided to shift this completely to an extraocular location. So that's how XNET came into picture. So XNET stands for Extraocular Needle Guided Haptic Insertion Technique. So now let me. So initially this started as a technique, simple technique, and later we realized that it's better to come up with an idea of a device so that it's useful for each and every one of us. So this is how the XNET needle is designed. So to its one end, it has got bent 26 gauge needle, which is customized, which means the length of it is more than the conventional needles. This is pre-bent and pre-loaded with dual protection silicone stopper. So the idea of the stopper is to temporarily stabilize the exteriorized leading haptic. Also avoids a dependency on the assisting nurse. To its other end, you can see there are sclerotomy markers 1.5 and 4. 1.5 is extremely useful for us to mark the sclera where exactly you need to make the sclerotomy and enter. So this is how we have designed the XNet device. So now let us move on to a surgical video. So this is a case of traumatic dislocated nucleus. I have done the lensectomy part. Now we are moving on to XNet. So these days I do sclerotomy, scleral grooves like this with using a bent side port knife. So idea is to have a wider opening for easy tucking. This is of course a modification of what Gabor Shariat has taught us in the past. So what you see here is a XNet device, the green thing, using the sclerotomy marker 1.5 mm away from the sclera, away from the limbus. And once you mark that, using the sharp 26 gauge needle, try to go inside. The initial direction should be towards the mid-vitreous, but once you pierce the sclera, change the direction, come more anteriorly and towards the corneoscleral section which you have made. So this is one limitation I would say, at least for the current version of XNet, you need to have this. And I'm using a McPherson forceps and trying to sweep, arc it out. So your tip of the needle is outside. You can see already the tip is outside, and I'm now docking the leading haptic of a 3-piece IOL inside. You can see 3 to 4 mm of docking is generally sufficient. Once you do that, gently retract the needle, and at the same time push the IOL inside. It should go as a single unit. You shouldn't be retracting the needle separately or pushing it too much inside. And you can see that we have done something outside. Now we are not going to do anything inside. No intraocular maneuvers for all practical purposes. Now we are going to do something outside again. So that's all about XNet. So you move the silicone stopper close to the sclera and keep the McPherson inside the foramen and wait for the haptic. Keep retracting the needle, wait for the haptic to come. So once you see that, catch hold of the haptic gently, disengage the needle. That's it. So simply we have transferred the silicone stopper to the haptic from the shaft of the needle. So move it further to the tip of the haptic and adjust it so that you get an additional length for the maneuvering of trailing haptic. So do the similar step on the other side. Use a marker and try to penetrate the sclera at 1.5 mm. If you feel the AC dynamics is collapsing, you can increase the bottle height of your setting, or you can increase IOP settings if you're connected to a machine, or you can simply close the lip of the scleral lip using cotton tip applicator. So now you can see the tip of the needle is intraocular now at the pupillary plane. So now you're going to again sweep around. You need to sweep don't try to penetrate. That's when you will injure the tissues. Just sweep it. You need to come above the optic plane, as you can see here. Use your McPherson forceps again. Keep it above the haptic and just make an arc. Bring it above the McPherson forceps, and your tip is outside. And keep it lateral as possible. And flip your McPherson forceps reverse. This is what I do normally, so that it's easy for me to dock at this stage. So simply retract the trailing haptic and push it forward into the lumen. So it gets docked. Again, 3 to 4 mm should be fine. It should be like an aeroplane landing on a runway. the tip of the trailing haptic should be facing downwards, and at the same time your needle should be receiving. It should be slightly depressed. So that facilitates the step. And simply retract the needle. So now take your McPherson forceps, go to the sclerotomy point and wait for the haptic to come. As you see the haptic, gently hold the haptic and disengage the needle like this. Yes, that's it. So XNet is all about this. It simplifies the way the haptics are exteriorized. Once you exteriorize, it can be combined with any of the fixation techniques. I normally use Shariat's tunnel, as you can see here, with a slight modification. You can always combine it with glued IOL or Emanis flange technique. That's up to the surgeon. But XNet is all about exteriorizing. So now I'm trying to take the tip of the haptic inside using the forceps. You can see one good tip I would say when you push it inside, look for the movement of the optic. If the optic moves, that means you are in the right track. You're very sure that you're pushed it correctly. So do it on the other side. Look for the movement of the optic. So the wide entry helps at this this step. Otherwise, it might be very difficult for you to push it inside. Yeah. So that thus completes the XNet procedure. Yeah. So we thought that everything is going smooth. We are done probably with XNet and the XNet device. That's when we realized that there is something else we need to do. So one fine day this happened. Check this video. So I'm trying to do the conventional handshake technique. I am catching the tip of the haptic and I exteriorize. Now I'm trying to push it inside the scleral groove which I have made, but there is a little more bleeding than what I expected. I'm having some struggle in pushing it inside. Oh, I think I've lost it, isn't it? Yeah, the haptic is inside, already is slipped into the vitreous cavity. Then I had to use retinal lenses to retrieve it and fix it again. So this again made us to think that this needs to be simplified. So that's how we got an idea. We came up with this idea called S-Fix, or S-Fix or suture guided haptic fixation technique. This is a technique device, I would say. This is not commercially available yet, but it's very close to that stage. So you can see a polyamide tube, a cannulated one, to which we have attached nylon 50 nylon suture. The other end of the suture thread is crimped to the 380 micron spatulated needle. So this is how the device is going to be. I'll show you an animation video. Yeah. So this is an animation video. The haptics are exteriorized. Now I'm trying to dock the haptic into the lumen of the polyamide tube. Again, 3 to 4 mm should be fine. You may dock it till you reach the suture filled portion of the device. Then push it inside. Push it completely inside till the entire polyamide tube is intraocular. Then what you need to do is simply take a bite, a suture bite, but start right at the point of sclerotomy. Just go anti-clockwise for fixing the haptics. 3 to 4 mm again should be good. Then come out, exit, and bring the needle out and pull the thread gently. Now, so as you're going to pull the thread, slowly you can see that the haptic will simply follow the suture track and get fixed. So we have made the suture thread and the polyamide tube junction strong by glue. We have provided a gluing length of 4 mm, but yeah, but the Haptic is going to come through without any resistance. So do it on the other side. Dock it, push it, take a bite, and pull. That's it. So as you pull, it's going to come. So let me just show you a video. So you can see I'm docking it first. So once you dock, and normally the Haptic is curved and the polyamide tube is straight. So once you push it inside, it snugly fits. There's no need to worry about slippage here. So take a bite. Roughly 3 to 4 mm. Along the direction into which the Haptic needs to be fixed, anti-clockwise on either sides. So I may give a counter traction to bring the needle out. Retract the needle and pull the thread. As you can see, as you are pulling the thread, the Haptic has to follow and get fixed in the suture track that you have made with the suture. So if you can see a tip of the Haptic outside, you can always use McPherson forceps to push it inside. So yeah, you can do it on the other side using the same device. You can clearly see that S-Fix doesn't require peritomy or flap or glue or even a forceps to fix it. All you need is a device, a suture device, to get it fixed symmetrically. So push the polyamide tube completely inside and take a bite of 3 mm. At either half or 1/3 thickness, scleral thickness should be fine. So pull the thread gently, keep pulling, the Haptic will come and get it fixed. That's it. You can see SFIL is well centered. So we've been doing this now, and the work is under progress, and very soon we'll be coming up with results and a commercial product as well. So thanks very much, Pondi team, for this opportunity. Yeah, thank you very much.
I mean, as usual, now you're making another step easier. Gabbar, a quick question for you. Will you do this?
Yes, I hear you.
The X-Fix, because see, a lot of people have difficulty in putting the suture into the chariot tunnel because it's so close. That's why glue dye became popular. You know why it became popular, right? Because there is a difficulty. So Prabhu is coming with an idea of, can we do it? Is simple. I mean, that's what innovators are. How do you make others do it simple? Which Gabbar can do, or Prabhu can do, or Naresh can do? Can everybody do? So that is what Prabhu is now working on, this idea called X-Fix, and now he's working very closely with Oral Lab and made it into a product also.
Yeah. I first of all, I think, or what I understood about the glued IOL was that one drawback of my technique might be that at least currently the forceps I'm using, which work very well, are a disposable forceps. And they are, unfortunately, this is not my fault, quite expensive. And you need to, I think it makes my technique easy to have these forceps. If you don't have them, it's becoming more difficult.
Correct.
And what I saw when I was visiting Amar Agarwal was actually that he's using 20 gauge forceps because they were available for him and they are reusable. And that makes the technique not so expensive then. And but he found that, okay, if I make a 20 gauge hole and bring out the haptic through a 20 gauge hole, I have to cover this hole. And that was the reason why he went back, I think, a little bit to the flap technique, which we know from the sutures. And then he found, okay, but then the IOL is not stable because the glue does not fix the haptic, actually. It fixed the flap and the conjunctiva, but not the haptic. And therefore, he understood he needs anyway the tunnel. But to introduce then into the tunnel was easier because he had more space. I understand fully that with my technique, it's more tricky to get into the limbus barrel tunnel. I like actually the X-neck technique because it externalizes the problem of dealing with the haptic. So I like that. What I'm afraid a bit is that this the manipulations I saw, and these were excellent surgeons, excellent surgeries, and I'm really happy to see that the worldwide adaptation and modifications of my idea, and that people more and more understand that intraspiral is the way to go. I worry a bit about, and this is also what I've observed with Yamane and all other techniques, is the bending of the haptics. I always try to be very, very careful to the haptics because at least in some IOL types, the haptics are not that forgiving as in others. And with the X-neck technique, I would suggest to maybe, I don't know how, of course, but just to suggest that you do not have to bend it that much while you bring it into the needle. With the is it S-fix technique, which I learned today?
Yeah, S-fix.
Yeah. So with the S-fix technique, which is also very interesting, actually, to bring I would say to bring a sleeve on the haptic. Is it right? What I understand? Yes. You bring the sleeve on the haptic, which is a great idea, I think. I'm just not sure. Will it work for every IOL type? Because I mean, if I compare the haptic of a sensor with the haptic of an Acrisoft, for example, they're totally different. The sensor is more stiff, much thicker. The Acrisoft is more flexible, much thinner. I do not have experience. Yeah. So, but I think of course. As you said, you should analyze your results. You should refine your technique, and why not? I think, you know, it's. I mean, you honored me too much, I would say, Venka. But I'm not Kelman, yeah, and this is not phacoemulsification. It's one interesting thing in our daily work and daily routine. And we have to deal with these insufficient or no capsular support. But I'm really happy about every technique that brings us closer to an easy for a technique to fix to the sclera. So whatever modifications we find, and this is what we saw also in phacoemulsification. The basic principle is always the same. We bring the haptic in the sclera, right? Yes. And phacoemulsification is using ultrasound to emulsify the lens material. And so here we bring the haptic in the sclera. We don't use a suture. We don't bring it to the iris, which I personally don't find a good solution, or in the angle or whatever. So whatever is comfortable and reduces the risk for complications, reduces the risk for tilt or decentered IOLs, whatever you technique find good and also affordable. This is also very important because I know that in a lot of places around the world, of course, money plays a much bigger role than here in West Europe.
Yeah. Okay, Gabor. I think we'll finish the last talk and then we'll continue the discussion. We have some questions also to answer. And we have another interesting idea from Vivek and Shiva Kumar also. Yeah.
Respected teachers, senior ophthalmologists, my dear friends and colleagues, I'm Dr. Nidhi from Immaculate Hospital, Chennai. So I'm going to talk about the new innovation, the Cmt Flex Iol for a treatment for aphakia. As we all know that all inventions come with the question why, and so did mine. We've been having the scleral fixated techniques for more than 3 decades, starting off with the sutured SF-Iol technique, whether it was the 2-point fixation or the 4-point fixation. And then everything was revolutionized when Gabor Chariot introduced the externalization of the haptic and tucking it into the Chariot's tunnel. And then from there on, there were lots of modifications of the existing technique, like the glued Iol technique by Amar Agarwal, where they made flaps and they applied glue to hold the flaps in place. And then came the Arvind's own technique of the X-nick, where they used the needles to externalize the haptics. And then came the Emmaculate technique, where they externalized the haptics and then cautery was done. But then these were all different techniques using the existing 3-piece IOL. So that is why we thought, why not come up with a new design that is customized for this treatment of aphakia. So there came the Cmt Flex Iol. As you can see, this is a single-piece hydrophilic lens with a specialized T-shaped haptics. So these T-shaped haptics, when pulled out of the sclerostomy, opens up and prevents the fallback of the IOL. Let us go through a couple of case scenarios. So this is the first case where you can see a 360-degree subluxated lens. So this was planned for a lensectomy, vitrectomy with a secondary Cmt Flex Iol. As you all know, for any secondary IOL, the 0-180 degree is very, very important. But that helps the stability and of the lens. So once the bleeders were cauterized, a 2 by 2.5 partial thickness scleral flap is being fashioned using a crescent blade. And then you can use some force to get the blade outside, and then the scleral flaps are created. Now 1.5 millimeters away from the limbus, a 23 gauge needle is used to make a sclerostomy. And that is done on either sides 180 degrees apart. This, now we have to deal with the lens. So we use the same needle and I pierce it into the lens to hold it in place and prevent it from falling back. And using the 23 gauge cutter through the other sclerostomy, a limited vitrectomy is being performed. And then a puncture is made in the posterior capsule. And the combination of cutting and suction, as you can see, this being a soft lens, the entire lens is being removed. Care must be taken in this case that we do not drop any of the fragments down or the nucleus, because as we are surgeons, we know how difficult and the case changes once it goes into the posterior segment. Since it was soft, there was no trouble here. So the entire lensectomy was done and the remaining of the vitreous was cleared. So this is the new Cmt Flex Iol. As you can see, the T-shaped haptics. This is being loaded into a normal foldable injector cartridge. So using the Pranav T-Flex Forceps through one sclerostomy, this goes through a 2.8 normal clear corneal incision. So the tip number 1 here is when we inject the IOL, we should make sure that the T junction comes out first, because this makes it easy for us to grasp either the head or the neck of the T-Flex IOL. Second, at this juncture, we should not pull it, because that is when it can actually detach from the IOL. So the remaining of the IOL is injected inside carefully. We can leave the trailing haptic either at the tunnel or sometimes above the iris. And you can see it is gently being pulled outside. The T actually pops out and then opens. And then once we leave it, because of the specially designed haptics, it prevents it from falling back. Just a small animation video clip to show how the whole thing is done. As you can see, when the loading is, make sure that the T comes out first, so that makes the whole procedure easy. This can be done to any of the foldable injector cartridges. Through a clear corneal incision, the IOL is injected, where the forceps is ready through the sclerostomy. The head or the neck can be grasped and gently pulled out through the sclerostomy. you can see the T opens up and then the shapes prevent it from falling back. Now for the other side, we use the handshake technique where you use the Nisi grasping forceps to hold one arm of the IOL and then transfer it head on to the other preneur forceps. And then you can see it is gently brought out of the second sclerostomy. So once it is out, you can see the IOL is well centered in position. Both the T-shaped haptics are outside, and then we can remove the trocars are removed. In this particular case, we are applying the glue to close the scleral flaps and the conjunctiva. Post-op day 1 picture showed few corneal folds and edema and some hemorrhage, as you can see on slit lamp examination. On 1 month post-op pictures, you can see clear corneas, round pupil, well reacting pupils, and you can see where the flap is, the conjunctiva is absolutely clear. And also we have done studies on UBM just to know the position of the lens in relation to the iris, and also OCT pictures through the cut section of where the IOL is placed underneath the scleral flap to note for the position and whether long-term erosions are happening. So far, we have almost 2 years of follow-up of some of the initial patients that we had performed these IOLs in. And we also have some recent publication both in the local state journals and also in JCRS about the lens. Moving on to the second case scenario. So once it was tested for a year, we thought why not take it to some of the challenging cases. So this was a second case where it was a 37-year-old who had traumatic aphakia for almost 10 years with secondary glaucoma, and he was on maximum medical therapy. So we had planned to do a trabeculectomy combined with vitrectomy and a secondary Cmt Flex Iol under guarded prognosis. So first, the glaucoma surgeon had planned to do a superior TARAB. So you can see a triangular being fashioned, a partial thickness groove, mitomycin is applied, antechamber is entered, the punch is made, and the surgical PI and the releasable sutures. Then we took over and we made the flaps 180 degrees apart. Tricot was introduced to stain the vitreous, because I always prefer to stain the vitreous, and you see a lot of vitreous strands in the anterior chamber, and you know that this is a key for any secondary IOL procedure, that we clear all the vitreous from the anterior chamber. Once the vitreous was cleared, this is the specially designed Nishi grasping forceps. As you can see, the crisscross serrations on the forceps. So this makes it easy to hold this hydrophilic material without slippage when we transfer it to the second hand. And then we have the specially designed preneur T-flex forceps, where you can see the broad end alone. So this helps to hold the head or the neck of the forceps, making sure it does not chip away the hydrophilic material or the IOL when we are trying to pull it out. So these are some of the two specialized instruments that are made for this particular IOL. Here again, you can see the IOL that is being injected slowly. You can see the T junction emerging out first, and it is grasped head on, that is exactly in the head, and the rest of the IOL is being injected now slowly, and the trailing haptic is at the wound, and then gently it is pulled outside through the sclerostomy. Now once the one side is done, now you can see it is being transferred to the other forceps. Being hydrophilic materials, they are really flexible, and there is less tissue damage during any of these procedures intraocularly. So once the lens is in position, now we have the second problem to deal with. You can see there is a sommering ring that is there. So gently it was maneuvered using a Sinski, brought into the anterior chamber. And now using the T-flex Iol as a scaffold with low bottle height and low parameters, a slow controlled phacoemulsification was performed. Care must be taken that we lose some of these fragments posteriorly, and that is where the IOL acts like a scaffold, preventing it from falling back into the vitreous cavity. So once that was done, saline is injected to clear any adhesions between the iris and the cornea and to release any of the traction, since this was a long-standing case. So once that was done, you can see the pupils have become round and you can see the surgical PI superiorly. And that was the end of the case. And then we had to close the scleral flaps and the conjunctiva with the fibrin glue, and air bubble was put into the anterior chamber. You can see the 1 month post-op is a post-op day 1. You can see a good filtering bleb with clear corneas. You can see the trauma on the scar on the cornea, but well-centered IOL and round pupils. And the patient is doing relatively well. So moving on to the third case, there are a lot of questions whether this can be done only by a VR surgeon or even anterior segment surgeons. So yes, it can be performed on table. As you can see, this was a complication after cataract surgery, left aphakia with asteroid hyalosis. So here we were not using a trocar. The only key is the eye should be formed well. If it is hypotony is there, then it becomes very difficult, or you can use an AC maintainer. As you can see, the IOL is being injected, grasped head on. Why I say the eye should be firm is we should also make sure that we do not lose the IOL during the first haptic grasp, because that it can actually dislocate like any of the SF IOLs and go and fall back into the vitreous cavity, which we have faced once. So make sure the first time you grasp it is good and don't leave the forceps till the first haptic is out. We can also use an AC maintainer in these cases for surgeons who are comfortable with AC maintainers. You can see the T junction that is out. And now we are transferring it to the other forceps. You can see what I meant by head on. That is the easiest method. It comes out. You can hold the neck also, because being flexible, it actually comes out through the sclerostomy and then pops and opens up and stays within the sclerostomy area. So once this is done, the surgery is over. Always prefer to use some amount of tricot into the anterior chamber, even though vitrectomy was done, just to check in the end of the procedure whether any cortical, vitreous strands are there. So we're just washing away the transluminal sternite. You can see there is no vitreous round pupils. So it can be done without the 23 gauge trocars, but AC maintainer is also a good option for doing these IOLs. Yes, complications are there in all forms of secondary IOL, so there is no denying it. There can be hemorrhage, there can be of the iris. In this particular lens, the questions arise whether there will be breakage of haptics. Yes, it has happened, but then it is only if you are trying to pull it too much without injecting the IOL for the first haptic, or sometimes when we do the second haptic, we trying to give more force. So over a period of learning curve, I think that problem can be solved. Slippage when pulling the other side, yes, it has happened. And sometimes when we have large eyeballs, so what we'll have to do is we have to make the sclerostomy slightly closer. Questions about late dislocations or iritis or glaucoma, we have not found out in our case series, because I think there is an angulation between the optic and the haptic of almost around 10 degrees. So that avoids the rubbing of the posterior surface of these lenses. So there's not much of pigment dispersion that happens. Exposure under the sclera was another thing that raised. And so far in our 2-year follow-up, we haven't had, maybe we are putting, even though it is a thicker material that lies outside, because of the scleral flaps, maybe it is not getting exposed. So complications are common for any secondary IOL procedures, and it can be managed. So I like to thank my team for working with me and continuing this journey for the last 3 years and supporting me. And the makers of the lenses are actually Appasamy Associates, who are actually producing these lenses, and they are commercially available. Like to thank the entire team. It's a great honor and a privilege to be talking in the same forum with Gabor Chariot and Sergio Canavera and Prabhu Bhaskaran. And thanks to the entire Arvind Eye Care system for giving me this wonderful opportunity. Dr. Haripriya ma'am has been a role model and a guide during my undergraduate days when I started my cataract journey in Arvind Eye Hospital. And Naresh Babu sir, who's been there throughout my journey of my retina. So special thanks to them. And Vivek Anand, who's always been a good younger brother and a good friend to me. So thank you all for giving me this wonderful opportunity. And I'll be failing if I forget to thank Venkatesh sir, a special one, because he's been a great teacher, an amazing inventor, because I think I invented something in 3 years, but he does every month. He comes up with a new innovation, and that amazes us and keeps us inspired. And he's also a very strong, silent supporter of my this thing. So I should just mention it that when I started this journey 3 years back, when I did my first presentation, I think it was Venkatesh sir who came up and supported me and told me about how things can be modified to make it better. And every time I make a modification and present, he's always helped me in this journey. And after 3 different generations of the Cmt Flex Iol, I think we have arrived at one particular design which is working easily. So special thanks to you, sir. Thank you once again all for this time hearing. And this times of COVID, I think the only solution is that we stay COVID negative, but stay positive in our thinkings. And thank you once again, everybody.
Keep the volume.
Thank you, Nivyan, for very kind words of appreciation.
Any questions, I would like to take them, and I think.
Thank you, Nivyan. I think we'll come up for the questions a little bit later. We have some time for that. So before again going to the questions, I think I want Shivakumar there now to quickly share his experience on how they do differently in Aphakia and what is their practice at the AEH Tirunelveli. Shivakumar?
Yeah, I think, can you see this?
Yes, Shivakumar, yeah.
I'll be talking about the longest living IOL, that's the iris claw, which is made of PMMA 8 to 9 mm, and it's got a cleft into which the iris can be enclaved. And the positive point of this is that it's quite easy to learn, doesn't have a very steep learning curve. The prerequisites being a 180-degree iris being available and the pupil becoming smaller than 5 mm. You know why? Because there are a few heart in the mouth moments where you can have some problems. But like anterior segment surgeons are not as brave as retina surgeons. 2 things common in all our speakers is they are great innovators and also retina surgeons. So we wouldn't like to go beyond much beyond the posterior capsule. So here is the IOL which is being placed in the anterior chamber, and the overall size is 8 mm, and it shouldn't sink. So the pupil needs to be constricted, and it's quite simple when you have 2 stab incisions, the paracentesis. You just have to enclave that iris into the cleft. Move this a little bit, see the enclavation mark on the iris, and you'll be able to be sure that this iris is fixated well. A few challenges are actually placing it right at the center and also fixing it to the mid periphery, otherwise you're going to end up with a cat's eye pupil. Or if you move down the center of the pupil while you're enclaving, then you can have a decentration. So these are some of the complications. And of course, like Gabor mentioned, there can be a wobbling if there is iridodonesis, and other complications like CME and pigment dispersion can be quite common. But all in all, this happens to be an easier technique and easy to learn, where you don't have to play for quite long into the vitreous. And probably the anti-segment surgeons will find it more comfortable. So we all started with the iris claw around 6 or 7 years back, and initially we did it in the secondary IOLs where we were sure that the pupil was small to start with. But later on, today, the ratio may stand at about 80-20, where primarily once we have a complication, I don't have adequate support, or if there's a whole bag removal, we go ahead with an iris claw fixation. The results have been good enough with the iris claw, and except for this cat's eye pupil or a mild decentration, it doesn't have the tilt like we have with the other IOLs. And many surgeons have picked up this technique quite easily, and barring a few complications of de-enclavation from one side because of either damage to the haptic or because of just the enclavation of the posterior iris or the pigment into the IOL, there can be a de-enclavation a little later, but usually all this can be addressed. So This is about the iris claw IOL, which actually helps you to get rid of aphakia even while you have a complication at hand.
Thank you, Shiva. Coming to our next very important panelist, Priya, how do you approach? I mean, what is your technique and whatever you have seen now, which is your practice and what you normally do in when you have an aphakic situation?
Yeah, I am also an anterior segment surgeon, so I do prefer the iris suture technique. So I think all these techniques work well. It depends upon the surgeon's comfort and the situation. Is it if you have a scleral scar, then an iris suturing technique may work better. If you don't have an intact iris or inadequate iris, then you have to go into the scleral fixation technique. I go with the suture iris fixation technique. I think more surgeons today are transitioning to the scleral fixation technique. And even those using iris lenses go in for the iris claw. But I still am using the iris sutured IOL technique. I think the iris claw technique, which was just described, is very good. I think many surgeons in RMI hospital as well are using this technique. We're seeing good results. On a personal note, I use the iris suturing. One, it can be used to support the lens temporarily. For example, during your, if you're having some support, and if you want to place the IOL in the sulcus and then you fixate the other haptic to the iris, then this is just one quick bite and you're tying the knot. Or there's a situation when you have no support at all, in which case I do two things. Either I place the sutures first on the iris and then retract the sutures through the main tunnel and then loop them across the two haptics and then place them in the sulcus and suture them. Or when I'm using foldable lenses, I place the lens completely in the anterior chamber and then only dial both the haptics into the posterior chamber while supporting the optic anteriorly above the iris using a spatula. So this is something which I've been doing more recently, and then suture both the haptics. So this has been a quick modification which I'm doing more recently now. And I again believe, I think that these are all excellent innovations, and it's important to explore all of this because there's no one fix solution for any of these cases. And I think it's good for us to have to be aware of many of these techniques so we know which one is applicable most in different situations. But I still use the iris fixation. Yes.
Paresh, I mean, is it still a posterior segment domain, or because we know Gabbar is a posterior segment surgeon? I mean, he does anterior segment part-time, some glaucoma part-time, but he rotates macula, no? So he's able to play, and you also play. And Prabhu wanted anterior segment surgeons to do. That's where he came up with XNet and XFix and all that. But still, fluidics is an issue. So, what is your thoughts, and how will you motivate anterior segment surgeons to do more of SF5? You had unmute, Naresh.
I am very happy to see Dr. Gabbar, and I was directly in his what you call OT, one of the best OTs I have ever seen. I am a big brand ambassador of Dr. Gabbar everywhere, actually, for the last almost close to 12 years. And the question is very important, sir. The reason why I am saying it should be done by the posterior segment surgeon is we have analyzed close to 1,311 eyes in the last few years, which had got at least 6 months follow-up. Our retinal detachment is 22 eyes, that is 1.7%. And most of these cases happened in cases with congenital lens subluxation. 3.4% of our congenital subluxation had retinal detachment. Why I'm saying this is addressing the vitreous, and as you have been telling, fluidics is also very important. So in that way, I think at least examining the periphery at the end of the surgery is very important, number one. And number two, we have analyzed 10 years trends, which we have published this year. Actually, the endophthalmitis rate in our cases are very high. We have analyzed close to 3,500 cases, which we have done in the last 10 years, and our rate of endophthalmitis is 0.112%, which is close to almost 3 or 4 times more than the regular cataract surgery. I don't know how many of you have analyzed your cases. So endophthalmitis is also quite high, but it is comparable with the rest of the secondary techniques. So, and the third thing, like we do Gabbar's technique because now we don't have the PMML lens. We have completely moved to AuroView foldable 3-piece, one of the excellent lenses, no financial. But this particular foldable cannot be used in case of XNIT or what you call S-Fix. So in that case, I think we'll have to go for GABA stick.
Okay.
And the last thing is, like, most of our fellows are trained only in Dr. Gaba's technique. The reason is when we are giving them too many options, they are also confused and they don't master anything.
I hope everybody gets an opportunity to get into Gabar's OT, which normally we can't unless you travel to Hungary or Germany now. But you had a unique opportunity of seeing, seeing him do, starting with the macular rotation, going to an eye stent, and then hydrus, and then whatnot. So,
No, just a minute. Sorry, sir. More than that, no, the patient comes, sits in a chair, the chair is moved, it becomes an operating table, it goes for rehabilitation. Finally, the table becomes chair, the patient walks away. So nowhere the patient is made to move from his chair. That was one of the best system I have seen.
Yeah. In fact, one of the Germany videos, which we used to see several years back, motivated us to even do a 2-table and high volume system and all that. Now they are so efficient, and we have seen some of the surgeons being highly efficient. And Gabar is one great surgeon like that. Gabar, you want to add anything to what Naresh is saying now? Do you think anterior segment surgeons can play with this in the future?
Yes, definitely. Definitely. I think anterior segment surgeons can do this. And I have seen a lot of anterior segment surgeons. One. Second, I think our world changed. No one as an anterior segment surgeon touched or went through the pars plana. Now everyone became routine in where is the pars plana by intravitreal injections, doing thousands of these every year. So we know where the pars plana is. And I think therefore more and more surgeons become comfortable with placing at least the pars plana infusion. And once you do this, you become comfortable with this. I think an anterior segment surgeon should not think that he is really limited and scared by the posterior capsule. So what we see, what I think is you are more fixed maybe to do the instrumentations from anterior. That means from your paracenteses and the corneal incisions. Than the retina surgeon, because he is more easy to switch between pars plana and the anterior incisions. But I'm sure that they can handle that. And look, what I see, for example, are differences that I put the leading haptic straight away into the vitreous, and anterior segment surgeons probably put them first on the iris to be sure that it cannot fall back. But the manipulations became so standardized and so safe that I don't think that there is a reason not to do intrascleral fixation as a clear anterior segment surgeon. Haripriya, I appreciate that you are doing the iris fixation still, yeah. But it's of course it's a good option if there is a good iris, etc. But I don't think I would not agree that it is an easy and quick technique. If you want to perform that well, you should be also a very experienced surgeon, because it's not so easy to bite through the iris without seeing the haptic, without causing a cat-like pupil, etc. So I think every technique has its own difficulties. Yeah? But the beauty of the intrascleral fixation, as I mentioned already, is you use a standard IOL. You don't need a special IOL. You are totally independent from iris. So even in aneuridia or after severe iris traumas, you can fix the IOL very stable. The IOL is never wobbling. Yes, is that way to really have a stable IOL that is not oscillating or wobbling, which I found that, look, also here in Germany, iris fixation, iris claw lenses are still popular, but I see patients coming to my clinic referred because they really suffer from these from the IOL wobbling, yeah, with the instability of the image, etc. And they really come, and once we change then after discussion and they decide for IOL exchange and I do an intrascleral fixation, then they are really happy after that. The image changes for them.
I'm not sure if it's the technique or it's just you taking care of them.
No. Yeah.
Yeah, so I think I agree. I mean, I think at the end of the day, it is what you're comfortable. As you said, in my hands, this works well, but it depends on what each surgeon is comfortable with. And end of the day, you want to have a quiet eye, controlled IOP center, less incidence of CME, iritis. So I think once we're able to do that for the patient, and of course, endophthalmitis. It's an important point because the rate of endophthalmitis is about 5 to 6 times higher in a patient with PC rent. It is double of that, more than a PC rent when you have, in a patient who undergoes a secondary IOL. So whatever the secondary IOL technique, Scleral suture, or the Gabor's sutureless technique or iris fixation, important to close the wounds completely, avoid hypotony, ensure the wound is well formed, suture the wound. Intracameral moxifloxacin, if one has access to it. I think it's important to follow those principles as well to have a better outcome. And of course, anticipate raised intraocular pressure, anticipate cystoid macular edema. All of this again is something which you may have to deal with post-op.
Perfectly agreed. Yeah. Priya, we'll quickly see one of your ideas and how Vivek has a little bit modified it, called single iris haptic fixation. And then we'll again continue the discussion.
So, good evening, everybody. So, I'll be talking about the single haptic iris fixation. So, we saw Madam explaining about the double haptic iris fixation. The single haptic is a little bit of modification. For example, when you have a case like this, a very hard nucleus with zonular dialysis, and then subsequently a posterior capsular tear on one side, you have a very strong capsular support on one half and a very weak area on the other half. What do you do in this case? Should we do a scleral fixated IOL, or should we do different double haptic fixation of the intraocular lens? So what I choose to do here is to do a single haptic fixation where one haptic is placed in the sulcus and the other haptic is sutured to the iris. So first, a little bit of meiosis is induced, about something less than 5 millimeters, and using a 9-0 or 10-0 proline suture with a long curved needle, a bite is taken from the limbus so that it passes through the mid periphery of the iris and comes out of the mid periphery on the other side and the limbus. So following the iris bite, I make a paracentesis right in between the two points of iris contact. This reason for making a paracentesis is to externalize the suture at the end of surgery. So once that is done, using a Kuglen's hook, the suture is externalized and then it is looped around the haptic multiple times. Once the looping is done, the suture is pushed towards the optic haptic junction in order to prevent slippage while trying to place the intraocular lens inside the eye. So here care has to be taken that the leading haptic, in this particular case, the leading haptic is going into the sulcus area above the rhexis margin. And then the trailing haptic is gently pronated and then released. Do not dial the IOL in such cases because the slippage is very common when we try to dial the IOL. So once this is done, the sutures are trimmed externally and then are internalized. So the suture is brought into the anterior chamber by swiping a spatula or a Sinski's hook. Once both the sutures are in the anterior chamber, using a Kuglen's hook, they are externalized through the common paracentesis. So now both the sutures come out of the common paracentesis. So once it's outside the paracentesis, then both the sutures are, the knots are applied and the sutures are tied. So this is done as a primary procedure. So the surgery, the advantage of the iris fixation IOL is you can do it as a primary procedure. You do not need any expensive equipment for this. So once the IOL is placed, viscoelastic removal is done, vitrectomy is done, and the anterior chamber is formed. So this is one other case where IOL explantation and a scleral fixated IOL was planned. But my initial thought was, we'll make a paracentesis, see if I can attain proper meiosis. So in this case, I injected a little bit of Pylomen, a little bit of meiosis was there. After careful examination using a Kuglen hook, I decided to do a single haptic fixation because one side was strong. So here, how do I know if the suture has passed through the underneath the iris? Is after taking the bite, as you have seen. So when you pull the sutures, you will see the IOL tilting, which is an indication that the suture has passed underneath the haptic. So before taking the bite, always use your Sinskey's hook to lift the IOL so that you see the indentation on the iris, which will give you an idea of where the optic haptic junction is, and you can take a bite there. So this is a secondary procedure where different things were planned, but the main advantage I see here is less postoperative inflammation in such cases. The pupillary reaction is not curtailed in any way. And reduced risk of suture exposure and suture breakage. And most importantly, less expensive. All you need is a 10-0 or 9-0 Prolene suture with a long curved needle and a Kuglen. Thank you.
Thank you, Vivek. Any of the panelists, any thoughts on the single haptic fixation?
So in all this iris fixation, the only issue is when one haptic is dislocated, to cut the second haptic iris we have come across. In fact, we used to fix the same lens if it's a 3-piece. Cutting the second haptic iris fixation is a bit difficult because sometimes we'll have to make a hole in the iris also. Otherwise, it's fine actually, but late complications are there with because those cases come to us basically, the iris fixation, because over a period of time, the iris also gives way.
Yeah. Welcome, Sergio. I'm sure you're between surgery and picnic. But anyway, thanks for joining. Welcome to the symposium. Any questions to Sergio from the panelists?
No, hello, my friends. I am in the beach now.
Okay.
Unfortunately, I am in holidays when I accepted this invitation. I didn't know this holidays in Brazil.
Oh, that's fun. That's fun seeing you from beach for a change, Sergio, because we are all sitting inside with the pandemic here. It's nice to see you.
Yes.
Gabor, you want to ask anything?
No. I'm only just a pleasure to be here with so important surgeons. What you need for my side, I'm here.
Yes, Gabor, you want to ask Sergio anything?
No, I just want to say it's not fair. It's really not fair what you're doing.
Gabor is the master in scleral fixation.
But I'm not sure. Is it just the background, or are you really at the beach?
You're really on the beach, here.
Oh, no! Don't show me! Don't show me! Don't show me!
Look, my son's at the beach. Look.
Beautiful, beautiful.
It's holiday here in Brazil.
Enjoy.
Thanks.
Sir, I have got a question for Prabhu. Can I go ahead?
Yes, sir. Sure.
1 minute. No, 1 minute, Naresh. I think we're going to relieve Sergio.
Okay, fine.
Yeah, Vivek has got a few questions. Yeah.
So hello, Dr. Sergio. So there was one small doubt about the capsular tension segment fixation using the Prolene suture. So I was wondering, while the suture is pointed downwards, when you pull the segment, is there any tilting of the segment from the bag?
Can you repeat, please? Sometimes the sound here is good. I understood you asked me about the CTS.
Yes, about the CTS fixation. Yes. While if the suture is pulled too tightly, Do you have any tilt of the segment or post-operative flip of the segment? Have you seen any?
Yes, if you use a flap CTS like the Armed CTS, you will have a tilt. I don't suggest you use the flat CTS. The best CTS I know is the Madhu CTS from India. I think you know this company, India, Madhu. The CTS has an angle, and you have an angle, it's avoid the tilt. If you do my technique with a flat CTS, it will tilt in the post-operative.
Okay, okay. Thank you, Dr. Sergio.
Anybody? Priya, you have any questions to Sergio?
No questions.
Prabhu?
Yeah, Sergio, I would like to ask you, how do you manage IOL tilt, if at all? What are the tips that you would want to convey across the board to manage IOL tilt in your technique?
Can you repeat how I manage what?
IOL tilt of IOL. How often do you come across tilt of your IOL?
In my technique with 4 points, I don't have tilt because you have 4 points in the sclera. When you use the traditional IOL scleral fixation with single PMMA IOL, and you fixate into only 2 points, if you don't have a good tension, it will be with no tension in the post-operative, and it will tilt. Then you can back to the operating room, and you need to pull more the polypropylene to avoid the tilt. Because this is important, as I told you in my talk today, you need to pull, holding the base of the sclera, and you need to make sure that the IOL will be in the sulcus. But in the four points in the sclera with foldable IOL, you don't have tilt because you have 4 points in the sclera.
Sure. Okay, thank you.
Thank you.
Some of these tips which are shared by the innovators are very important. If you're not going to do that in the right way, I'm sure people give it up after some time. So that is where I think some of these lectures are very important, to listen to the innovators, and the early adopters make a difference. That's what I've seen. When you have a technique with a good early adopters, it passes like a tsunami. There are so many people who do that. Otherwise, it gets lost in the crowd sometimes. So yeah, Prabhu.
I'd like to ask the same question to Dr. Gabar. SFL has got this issue, isn't it? Tilt of IOL, unlike iris claw or iris fixation, because getting that symmetrical point, sclerotomy point 180 degree away is crucial, isn't it? So what are the tips that you recommend or you take care when you do SFL surgeries, your Gabar-Shiret's technique, to avoid IOL tilt?
I usually do not mark the cornea, so I just put the needle over the middle of the cornea, and then I know where 180 degrees is. But I think it's quite helpful for beginners if they make 2 points on the limbus with a marker, with ink, and then they know exactly where they have to place the sclerotomies. The second very important is, as I already mentioned before, be very careful, handle the haptics like a raw egg, because once you break them, you bend them or whatever, you can also get a tilt from this. And this is almost not possible to handle an intraoperative. And with seeing all the other techniques, I still believe, and I hope I could explain that in my presentation, that the sutureless intrascleral fixation technique with a tunnel is the only one where you can do at the end a fine-tuning. When you can pull a bit more out of the tunnel or a bit back, and then you center the IOL better, or you reduce the tilt. And the tilt is also is 2 questions. One is if it is not 180 degrees exactly from each other, and the second is that it should be also the same distance from the limbus. So I got patients after previous surgery where one haptic was in the ciliary sulcus and the other one was in the pars plana. And of course, this causes also a tilt, an intraocular tilt of the IOL.
Do you think is there a need for making it more precise, like how anti-segment surgeons used to have something like Varian for toric IOLs? All what we do now is manual. It can vary from person to person. So, do you think that this has to be more precise in the future?
Not really. I think it complicates more the surgery than it is helpful. I think the main problem is, you might do 1,000 phacos a year or more if you are a high volume cataract surgeon, but still you do just a couple of scleral fixated or iris fixated IOLs, never the same number. And so the experience will never be the same. It will be never as easy as your routine phaco. And I think this is the major difference.
Absolutely. Agreed.
Naresh?
Yeah, with Dr. Gabar's permission, two things. One is like we totally stopped making the sclerotomy openings at 3 o'clock or 9 o'clock meridian. Because when you go at 3 or 9 exactly, many of our cases were initially having vitreous hemorrhage because there is a chance that we are damaging the LPCA. So what we have done is slightly maybe 8 o'clock and 2 o'clock or 4 o'clock and 10 o'clock is the one which we are making now, number one. And number two, like when Prabhu was asking about the decentration, initially we had a lot of decentration, especially with foldable. One way to overcome is your pocket should be tangential to the limbus. And when you are making the entry should be towards the center of the cornea and never away from the cornea. When the tunnel is away from the cornea, there is always a tilt happening. But when your haptic is towards the cornea and tangential to the limbus, it follows the curvature of the lens haptics. Never we have the tilt of the lens. And we have come across tilt more in foldable lenses when we are using the sensor. But now with the RVU, it is very, very less. And as I was told, telling it should be towards the center, the pockets. I think Dr. Gabar will agree with that.
Yes, I agree with that. The only thing I wonder is, but I'm not sure the reason for is, I very, very rarely put my my haptics at 3 and 9. I'm almost all my cases I put 6, 12 o'clock, and I'm quite happy with this positioning.
Yeah, but
and I don't sit. Maybe one reason is I never sit at the temporal side.
Okay. No, in 3 and 9 we used to have hemorrhages initially, but when we shifted to 4 and 8 or 4 and 10 or 2 and 8, it has almost disappeared sort of.
Okay, so it's time for some of the audience questions.
So we have two questions. The first question, what technique will be best suited for pediatric age group? For example, a 5-year-old child with subluxated cataract.
Who's this? Who has to take
By
Gabar? Gabar?
Yes,
What do
Dr.
you do?
Gabar.
Once again, please. I understood in pediatric subluxated lens.
Yes.
Yes.
Very much depending on the age of the patient. I personally did a few pediatric cases, trauma cases, and some congenital colobomas, etc. These are really challenging cases, and I think the most important is to understand that the sclera is different in these children and in young patients as well as in myopic patients. So it's much more elastic, and there is a much higher risk that you have a leakage and you have a slippage of the haptic. So it's not stable there. Otherwise, I don't think it's so you have to suture, and you have to make sure that the eye is not getting hypotonic post-operative. Otherwise, I don't see really a contraindication. Of course, the eye is usually smaller, so you have to probably be more careful. And I don't see a contraindication because anytime you can exchange even the intrascleral fixated IOL. Very easily, you just pull it out inside. One change I make in young patients is that because of the higher risk of slippage of the haptic, at least with my technique, is once I went through the limbus parallel tunnel and the haptic would be then looking a little bit out of the tunnel, I take a needle holder and bend it a little bit, the haptic, so that it becomes like an anchor. And since I'm doing this in the young patients, I've never seen a dislocation. So I don't think there is a contraindication for intrascleral, and I think intrascleral is better than any other technique if there is no capsular support, even in pediatric cases.
So, Sergio, you have any experience in pediatric eyes?
In pediatric eyes, I prefer to give the patient with aphakia. I like to do a scleral fixation in patients older than 14 years. I follow the patients, and after 14 years, I like to do the scleral fixation because the same things that Dr. Gabor told. The sclera is not a good option to implantation to do a scleral fixation in young patients. I don't like. I like to follow it, and when for complete more than 14 years old, I implantate the IOL. Is my whole team.
Okay.
So we have a question from Anirban Chakrabarti.
Can I add, Venki, can I add something?
Yes, yes.
The problem is, as I'm working also in some parts of Europe, believe me or not, where even contact lenses are a problem, keeping a child aphakic might cause amblyopia. And therefore, if one eye is phakic, the other aphakic, then sometimes, in most of these cases, actually, I would indicate an IOL. And as I explained, there is no reason why not to exchange later when they become myopic because of the growing of the eyeball, than to exchange the IOL. Yeah. Okay. So there is no one solution. So if they can get contact lenses, Sergio, I agree, then it's also a good option. But in some places, this is a problem, and the follow-up of the patients, etc.
Thank you. So we have one question from Dr. Anirban, where in high myopic eyes, what are the problems faced while doing a scleral fixated IOL, mainly while tucking the intraocular lens?
Naresh? Unmute.
As you were saying, actually, there is an equatorial extension of the eyeball also. So the overall diameter is not sufficient for sometimes in a large eyeball. And of course, sclera is also very thin. Only thing is like if, like as Gaba was telling, like you have to hold the tip of the haptic, even if 1 millimeter of or more than 1 millimeter of the haptic is snipped, better you would discard that lens and go for a fresh lens because we are using PMMA lens and it should not cost us more. Just to, because we are lazy, if you go ahead with that stipped haptic and if you're going to tuck it, maybe within few months, you are going to get a subluxated lens. And if you're going to again refix the same lens, especially in myopic eyes, again, it's going to subluxate. So better, you should have no snipping of the haptic when you're inserting, and don't tuck too much on one side so that you maintain that equilibrium on both sides, especially when the eyeball is very large. And of course, the sclera is going to be thin. While making a pocket, we have to be very careful.
Nivyan, you have any thoughts in, because this question keeps coming for your lens, right? In long eyes and short eyes, what is the option? You still do the CMT flex?
I think Naresh has already told the key points. But yes, we have to measure the diameter. So sometimes if the vertical diameter is slightly lesser, we can actually do it vertical also. But overall, I think these are all very thin scleras. So I think care should be taken when we make the tunnel, the Chariot's tunnel, so that we use a sharp needle. And he said the externalization should be equal on both sides, because initially even I had the difficulty when we tuck more on one side, the other side tends to slip. So I think good externalization of the haptic. Naresh, can we go a little bit more anterior when we make the sclerostomies in these myopic eyes?
I have never done Nivyan. We usually go at 1.5.
Yes,
in fact, the anatomy is also altered because you will have a wider ciliary body in these cases.
So Venkatesh, people have asked me this question for my lens also. So right now we have a standard size, but I think it can be customized for these large eyes.
Okay.
Because otherwise it tends to slip when we pull in the other side.
Oh, what is the size, Dr. Nivyan?
As of now, the overall thing is 14 millimeters.
14. Okay.
Standard size.
So is there a place for a larger IOL for myopes? Like we have an overall 13 for all three pieces. So would that help? And another thing is a polyvinylidene fluoride haptic is recommended, though not freely available. So what is the status about that? Has anyone tried? It doesn't deform easily. I guess Gabor can tell that.
Because right now it's a single piece lens. That the biggest challenge is fusing these two materials and then making sure that doesn't give way when we are actually pulling it out. But that idea is still there, and we have started working on it. So I think we need time to get the answer for that.
Gabor, how much of vitrectomy, and will you induce a PVD in cases where you do SFI?
Frankie, please forgive me. First, I wanted to say to the high myopes. So if really the anterior segment becomes so big that I have problems with the overall diameter of the IOL, usually I would not implant an IOL. So if someone has a 32 millimeter long eye with extreme measurements, usually it doesn't matter for him whether he has a 3 diopter IOL in the eye or not. That is what I believe. And do not take the risk of any IOL putting with 3 diopters in these eyes. It makes no sense for me, at least, or a -3 or whatever. Usually they don't care, whether they are +1 or -1 at the end. This is my honest opinion to these extreme eyes. And otherwise, usually if they don't have an extreme anterior part or anterior segment, usually the IOL is the overall diameter is sufficient. It's true, it can be if you pull too much on one side that it slips out on the other. So be a little bit more careful in these myopic eyes, but otherwise usually is no problem. Probably also because I use the 6 and 12 o'clock position, and then the distance is a little less. And now I forgot what was your question actually to me.
How much vitrectomy, and will you prefer to induce a PVD?
No. Yes and no. So if I do only from anterior my intrasperior haptic fixated IOL, that means no pars plana vitrectomy, then I do not intend to do this. If in any case, when I do a pars plana vitrectomy, I introduce a PVD. And the reason is, there are 2 reasons for me. One reason is if I don't do so anyway, it will come later. And it's better to control intraoperative, a tear which is caused by the PVD, then later when the pupil is getting not wide, I do not see well, then to do the vitrectomy or whatever. The second reason is I want to reduce the risk for some vitreous remnants on the posterior pole causing epiretinal gliosis, etc. So if I do a pars plana vitrectomy, then I always, in all cases, I introduce a PVD. If I do it just from anterior secondary implantation, I do a deep anterior vitrectomy. And that is the reason why I believe that an anterior segment surgeon can learn this technique.
So just a brief point, actually, as Gabor was telling, we cannot do anything less than 10 diopters because we don't have lenses below 10 diopters. So all our cases are above 10 diopters.
Okay. Yeah, that's what he was very stressing on. Extreme ways, it's better to even avoid than implanting a -2 or -3 for the patient.
Yeah. Otherwise, also we don't have in our inventory. It should be custom made if at all patient is insisting.
There are some people who wanted to share videos of iris sutured and other things. I'm sure we can share. Many of that are in our YouTube channel or our Tube also. So
I have a question for Dr. Prabhu. So I've been doing the XNet. I've been trying that. I've tried that a couple of times 1 year back here. So I had a problem with the trailing haptic always. No, the trailing haptic always it bent, or in a case it also broke. Do you have any tips for the trailing haptic?
Yeah, Vivek, yeah, I agree. This is, docking the trailing is a little more trickier than the leading one. So what I have also learned, over a period of time, what I normally do these days is I flip the McPherson. I don't hold the McPherson the way normally we, use it for cataract surgery. I flip it purposefully so that I hold the aptic perpendicularly. So when I hold it perpendicularly, my control over the aptic is good. So I can actually, as I said, you will have to bring it like an aeroplane landing on the runway. I ensure that the tip of the trailing aptic is towards the lumen of the 26 gauge needle, and I slightly depress the 26 gauge needle so that I receive it. So when I do this, it goes in easily. If I try to imagine, your aptic is facing upwards and needle is facing upwards, you can't probably dock it like this. So it has to be the contour has to be kept in mind. So that will solve the issue, I believe.
Thanks. So one last question on how to avoid iridodialysis or cyclodialysis while making sclerotomy during SFIOL in patients with trauma or with pre-op dialysis after surgical aphakia.
Okay. Any tips for that, Gabbar? You want to go for it? Because you do a lot of cyclodialysis, right? That's why we are asking you.
So the first is, as I always mention, for each step I use a fresh needle, so that it should be really sharp. I felt also when I went around the world showing my technique, and I did not bring my own needle, that from company to company they do not have the same sharpness. So make sure that you have a really sharp needle once you go through. The second is there are two moments when it can happen. The first is when you do the sclerotomy. So then make sure that you go towards the center of the eye, or even a little bit more posterior, more angled, more steeper, than instead of going flat. What I observe when I train surgeons is, especially beginners or anterior segment surgeons, they have the tendency to hold instruments more flat than a retina surgeon. A retina surgeon always have the tendency to keep the instruments like that, which prevents actually the dialysis. And then the other thing is, as I personally still believe, I want to have my I'm very happy if I have the haptic going in through the tissues in the ciliary sulcus. So I try to go anterior. In the moment when I go in and I see that the iris is moving, then I know I am 0.5 millimeter too anterior, and I make a second sclerotomy 0.5 millimeter more posterior. The second moment when you can cause a dialysis is when you manipulate with your forceps. You go in with your forceps. And the reason, mainly in my experience, is that the instruments are introduced too flat, not steep enough. I think these are the two reasons. And I remember, I mean, I would not suggest that as a routine, but I remember exactly as it was mentioned in trauma cases, or where there are a lot of scarring or whatever, that I hold it also from inside with a second instrument when I could not go in. Yeah, so even this can be helpful as an extreme solution. Yeah, but the major reason, I think, is wrong positioning of the sclerotomy, blunt cannula, and the wrong angle while you introduce your instruments.
Thank you, Gabbar. Thank you again. I mean, I really appreciate all the great innovators and also the panelists who are also innovators in their own field joining us today for this excellent session. And of course, the recordings will be available for people who have missed this session. But again, I would like to stress this point to all the young ophthalmologists who are still watching with us. Remember that slide which Gabbar showed you. It was a reject in 2006. This technique was a reject, immediate reject. it is dangerous. And what was the other term, Gabar?
Unneeded.
Unneeded. Okay, unneeded and dangerous now has become kind of talk of the town in a couple of years, and incrementally it has come a long way. So I see, that is how I think some ideas can be kind of immediately stamped and said this is dangerous or unneeded. Now that's why I compared you with Kelman when he had to go and dance to market his phacoemulsification in TV shows and radio shows. Now, because people said it's dangerous in an academy meeting, why do you want to put an ultrasound into the eye? I mean, these are out of the box thinkings, and some of the ideas which people have shared today are out of the box thinking. So we need to think out of the box so that we can make every surgeon do the best to our patients. That's the idea of innovation and the idea of the symposium. And we'll hope to continue this every 3 or 4 months to bring in innovators and share some interesting innovations. I again thank all the speakers and panelists, and Sergio has just disconnected. I think he's back to having fun in the beach, but it's nice to have you all.